Hello everyone, I'm Destina and I'm going to be talking about junior doctor workload and how that leads to burnout and the impact that it has on morale. So firstly, I'm going to talk you through a typical foundation year one's doctor's day and highlight any concerning aspects. Um, at 8 o'clock, they arrive on wards. At around 8:30, they'd conduct a ward round with registrars and consultants, and they'd usually check in on patients and play a clinical um, part in creating jobs such as floods and writing discharge summaries and distributed between themselves. Then 12 o'clock after the ward round, some nurses may contact them and to tell them if a patient is deteriorating, and you'd either have to deal with their situation or you would pass it on to a senior colleague if it was more serious.
Then around 2 o'clock, they'd head back on the wards to continue to complete any jobs or tasks and ensure that everyone on the ward is working well and everything is running smoothly. They'd work hand in hand with nursing staff and speak to patients' relatives to update them either in person or over the phone. And about 6 o'clock, they'd finish work. But bear in mind, a lot of junior doctors work overtime to serve NHS staff shortages or to gain new skills and long hours of progression. This is a typical routine of a junior doctor, but due to the way the NHS has come to quite a fragmented and crippled state, this only puts more pressure on junior doctors, with many having to skip meals. Hence, that raises questions on how well the NHS nutrition their staff, which is a basic necessity. They have to work long, unsustainable hours due to staff shortages. They may have to skip important life events. For example, on the BBC News, there was an example of a junior doctor who had quit her job and spoke about how, despite her long hours and commitment to her job, she wasn't guaranteed a day off for her mother's graduation. This toxic work environment demotivates and extinguishes the spark and excitement that many doctors had stepping into their first paid role. On the next slide, there are some shocking statistics putting into perspective how unsatisfied junior doctors are. So the GMC's 2022 National Training Survey showed that 39% of junior doctors reported very high levels of burnout, with 51% describing their work as emotionally exhausting. Many report missing proper breaks, missing meals, and having poor access to basic facilities, for example, Wi-Fi. And in 2019, only 37% of junior doctors stayed in training, which went down from 71% in 2011. It's horrifying to see the doctors having completed med school, which is around 5 to 6 years. Even how competitive it is to even get into med school, then quit. This percentage of 37% shows approximately 4 in 10 decide to not continue their career in medicine. That's it from me. I'll pass on to the next presenter.
Training pathways. The NHS faces limited clinical placements, rigid postgraduate pathways, and high supervisor burnout, which reduces the quality of training. Regional and specialty imbalances mean some areas struggle to access sufficient opportunities, while healthcare support workers often face barriers such as a lack of time, funding, and learning resources. Efforts like the NHS Long-Term Workforce Plan aim to expand training through accelerated degrees and more spots. But bottlenecks in mentoring and funding slow progress. There is a clear need for more flexible career pathways, stronger support for trainees and supervisors, and better distribution of training resources across the UK.
A major group that makes up the NHS workforce is international medical graduates, often referred to as IMGs. What are IMGs? Well, IMGs are doctors whose primary medical qualifications were achieved outside of the UK. The main route for IMGs into practicing in the UK is passing a licensing exam called PLAB, or obtaining GMC-accepted postgraduate degrees. Currently, IMGs make up approximately 1/5 of all licensed doctors in the UK. The GMC found that 2/3 of registrants qualified outside of the UK last year, with the highest proportion of overseas doctors coming from countries such as India, Pakistan, Nigeria, Italy, Greece and Egypt. Next slide, please. What are the benefits of IMGs in the NHS? Despite qualifying abroad, IMGs play a crucial role in the NHS by reducing the impact of workforce crisis, by helping to fill the gap of ongoing staff shortages, enabling more patients to be seen, and in the long run, reduce the NHS waiting list times, which has been a major issue the UK healthcare system faces. Additionally, IMGs provide their diverse expertise and dedication to strengthen Britain's public health system, particularly in valuable areas such as general practice, where staffing shortages are seen as severe. However, there are some challenges linked to international recruitment. One disadvantage to IMGs is there has been reports of IMGs struggling to adapt to new healthcare system due to the difference in clinical practice, communication styles and procedures, and not always getting the support they need to adjust. Another disadvantage is that the competition ratios for specialty training posts have massively increased, meaning locally trained doctors have found it harder to secure a training place, leaving them either stuck at the same level for prolonged periods of time or in some cases unemployed. Next slide, please. What is the government doing? In response to these challenges, the government has taken steps to improve recruitment. From 2026, the government has brought about new legislation that prioritises UK graduates as well as graduates from countries such as Ireland, Iceland and Norway for specialty training posts. This aims to give more opportunities to locally trained doctors. As well as prioritisation, the government is increasing the number of training posts available, so more doctors are being trained and progressing in their career. This would also lead to more specialist care being provided to patients and improve patient care in the future. In terms of IMGs finding it difficult to adjust, the NHS has rolled out a national induction programme to support IMGs transition into clinical practice by helping them understand NHS systems, professional expectations and patient safety standards. Overall, IMGs contribute a significant amount to helping the NHS provide quality care for patients, and with the right legislation and support in place, high standards of care can be maintained whilst also making sure our locally trained doctors have job security and career progression. Thank you.
Impact of workforce shortages on safety. Lower amounts of staff mean that staff have decreased time per patient, increasing risk of missed symptoms and delayed care. Post-op mortality cases have been associated with levels of nurse staffing, particularly for older patients. Survey of NHS shifts show how when staff feel understaffed, serious safety events are reported more frequently and essential care gets delayed. Fewer staff also means more staff working longer shifts, leading to fatigue and burnout. This can affect concentration and decision-making. Only around 1/4 of NHS staff state that there are enough staff to do their jobs safely. Impact of workforce shortages on waiting times. NHS 18-week target is a standard for ensuring patients start consultant-led treatments within 18 weeks of being referred by a GP or another healthcare professional. Fewer doctors, nurses and diagnostic staff lead to longer waits. 3 million patients have waited longer than the 18-week target. This has led to delayed diagnosis and can allow conditions to worsen even more. In A&E departments, the workforce shortages cause delays in assessment, treatment, and admission. Only around 75% of patients are seen within 4 hours at A&E. This causes overcrowding and unsafe conditions inside waiting areas. Overcrowding has led to 1 in 5 patients being treated in hospital corridors while waiting for beds at the expense of patient safety and dignity.
The NHS also experiences dental recruitment and retention crisis. So we are all aware of the current NHS dental shortage, which is a problem that is largely driven by an ongoing recruitment and retention crisis. Historically, this crisis was mainly seen as a geographical issue, which affected rural and coastal areas more than others. However, this is no longer the case. Today, problems with retaining dentists are becoming far more widespread, with both urban and rural areas across the UK being affected. So in 2021, the General Dental Council released some data stating that there is an increase in dentist registration numbers from 35,000 to 43,000 in the past 10 years. Following that, in 2022, the Department of Health and Social Care also released some data stating how more than 2,500 dentists across England and Wales ended their NHS roles. When we look at the statistics, it becomes clear that the UK does not have a shortage of dentists overall. Instead, the issue lies specifically within NHS dentistry. A growing number of early career dentists are choosing to invest their future in the private sector rather than the NHS. At the same time, many established dentists are also moving away from NHS work in search for long-term security, while other members of the dental team are reconsidering their career paths altogether. There are several factors that influence this recruitment and retention crisis. The first is UK graduate recruitment. Increasingly, dental students and new qualified dentists report seeing little future in NHS dentistry. As a result, many envision a career in private work or consider migrating earlier in their careers. This reduces the number of professionals working within NHS primary dental care and worsens the access for patients who rely on NHS services. So moving on to the next slide, another significant factor is the impact of the COVID-19 pandemic, alongside existing NHS pension restrictions. These pressures acted as a catalyst for many older dentists to reevaluate their positions within the NHS. For some, this led to reduced NHS commitments, a shift towards private work, the sale of dental practices, or early retirement. While this created more opportunities in the private sector for younger dentists, it also contributed to a further decline in NHS workforce numbers. Social media has also played an important role in shaping career aspirations, particularly for early career dentists. Online platforms often promote cosmetic dentistry and private practice with very little emphasis on oral health promotion or caring for vulnerable patient groups. At the same time, negative media coverage of NHS dentistry is widespread. A notable example is the widely broadcast incident involving a tooth extraction using pliers, which was discussed on the Jeremy Vines show. As a result, there is a growing perception gap, also known as a diffusion gradient, between NHS and private dentistry, which encourages more dentists to leave the NHS sector. Finally, retention within NHS dentistry is influenced by a range of push, pull, and stay factors. Push factors include higher pay and greater flexibility in the private sector. Private dentistry often pays more for the same amount of clinical time and allows dentists greater control over their schedules, including proper lunch breaks and a better work-life balance. This flexibility can lead to high-quality patient care and allows dentists to develop special skills. On the other hand, a major pull or stay factor for the NHS is its pension and job security. Leaving the NHS often means giving up a valuable pension. Additionally, the NHS can offer financial stability as seen during the COVID-19 pandemic when practices were closed but NHS dentists continued to be paid. This is a level of security that is not typically available in private dentistry.
In conclusion, while the UK does not lack dentists overall, NHS dentistry continues to struggle due to a combination of structural, financial and cultural factors. Addressing these issues is essential if we want to improve recruitment, retain skilled professionals and ensure fair access to dental care for patients across the country. Thank you. Oral health inequalities. Unfortunately, across the UK, there are many different oral health-related inequalities. And inequality comes with many branches, such as the divide between private and public healthcare, where more and more dentists are leaving the NHS, leading to those with lower household incomes to have less access to oral health care. This also includes those who suffer with disabilities and mental health-related issues, where basic hygiene needs are harder for those to succumb. And although there's less evidence regarding inequalities regarding ethnic minorities and those are part of the LGBTQ community, it is important that they also don't go unnoticed. A survey initiated in 2024 found that 34% of adults could not afford dental charges, whilst 12% said that they couldn't find a dentist at all. In 2024, it was also found that there were 24,543 dentists affiliated with the NHS, which roughly equates to 42 dentists per 100,000 people. Therefore, those who try to seek aid regarding oral health have a high chance of being unsuccessful, purely due to their financial positioning. In the UK, tooth decay remains as a prevalent reason for hospital admission amongst children. Children from lower household incomes are twice as likely to develop caries. This is due to a number of factors, such as poor diet, lack of access to education surrounding oral hygiene, not being able to afford toothpaste, and many more. This recent data, although disturbing, comes as no real surprise. For paediatricians and other healthcare workers on the front lines, poor oral health is one of the more apparent and prevalent health inequalities, and crucially highlights the level of poverty and deprivation in England. Tooth decay remains as the most common reason for hospital admission. These kinds of disparities are unacceptable in a nation as rich as our own. We know that tooth decay can easily be prevented by sustainable healthy changes in diet and the establishment of good oral hygiene. We also understand that the government are trying to initiate toothbrushing schemes for children, which will no doubt make a difference in the prevention of tooth decay. Though we note that no decision has been made on the calls for implementing mandatory guidelines on the amount of sugar and salts that baby food can contain. Around 6 million people in England are supplied with artificially fluoridated water, and approximately 300,000 with naturally fluoridated water. The chances of adults developing dental caries could be reduced by approximately 62% if they were to have access to fluoridated water. This is due to studies communicating how strengthening the microbiome of teeth from childhood has a significant impact on the chances of tooth decay later in life. Tooth decay can negatively impact a person's quality of life, consisting of pain when eating, infection, struggles with self-esteem, inconfidence, and many more. Those who are part of the elderly community also struggle to maintain the health of their teeth due to them being in care homes or having their needs dismissed by many people. Thank you.
Okay, thank you all for listening. I'm going to send out a form in the chat. Please fill it in whether you're an attendee or a presenter to get a certificate. But other than that, thank you for coming. And thank you to all of our wonderful presenters.